So let me just present a case of the patient I'm likely to see on Monday morning, somebody I think y'all have seen. 69-year-old man comes to us because he's now jaundiced. He developed new onset diabetes fairly recently, but he was overweight, so they thought he had type 2 diabetes. His glucose became more erratic. He'd lost about 40 pounds. He finally got a friend to see him and said, "Hey man, you're yellow, you need to go see your doctor." So he went to see his doctor, and lo and behold, he was icteric or jaundiced. He did smoke in the past. He really has no other symptoms other than being yellow and losing weight. He recently had his gallbladder removed, which is something we see very, very commonly in these patients. He had a CT scan, which I'll show you next, and his laboratory studies here are remarkably abnormal. So a fairly classic case of pancreatic cancer. So this is his CT scan. I don't know if we need the lights down. I hope you all can see it. The liver's here. The ducts are a little dilated. The gallbladder's a little big. We see the pancreatic duct is dilated, which suggests there's something blocking it. On another cut further down, we see a large pancreatic mass. So by definition, this patient probably has pancreatic cancer. The question that we face every day is, okay, what do we do next? And so I'd like to take more of an endoscopist, a GI approach that you and your patients and families will run into, I think, on a daily basis. So give you a little bit of familiarity with this. What is the approach? Well, we know at the time of presentation what we see with pancreatic cancer, only about 20% plus or minus are resectable. And if you take the patient to surgery, I think the techniques may be a little bit better now, but maybe half plus or minus can have the tumor removed. The question would be, how can we do a better job at really telling the surgeon, figuring out which patients are the best patients to get surgery so that those that don't need it don't have to have it. So a little bit of anatomy I think is important for you, the families, to know. So again, the liver's here, gallbladder's here. The pancreas lives right behind the stomach. Here's the pancreatic duct here. Here's the bile duct, which goes through the head of the pancreas. Many patients, of course, get jaundiced if they have a tumor in the head because it blocks the bile duct. You might say, hey, I thought there's these fancy CT scan called this PET scan. Well, can't that tell me I have cancer? Well, this is that patient's PET scan. Nicely lights up the pancreatic tumor, but still, I think we all want tissue. The oncologist wants tissue. To get in chemotherapy trials, you need tissue. So that's really the answer. We know this patient has cancer. What's the best way to both get tissue and stage the patient best? So the modalities that I'll briefly touch on are endoscopic ultrasonography, or EUS, ERCP, which is endoscopic retrograde cholangiopancreatography, where basically we take an X-ray of the bile duct and the pancreas duct from the intestine. And finally, the newer kit on the block, or cholangioscopy, that is directly looking at the bile duct to look for tumor. So again, why is tissue important? Well, there's benign and advanced disease. We want to get the patients for the surgeons to have the best chance of having a resection. We don't want to have a big operation if they don't really need it. And secondly, if they do have cancer and can't get surgery, we'd like to get them on some protocol so they can get neoadjuvant treatment, perhaps get surgery at a later time, but at least get some type of treatment. So the way we can get tissue at ERCP, we can actually brush or scrape the stricture to find cancer cells. We can take biopsies. I'll show you how we can do that at endoscopic ultrasound. And finally, a newer tool, a so-called spyglass, where you're directly looking at the bile duct to get directed biopsies. So we've come a long way, baby, as far as how we can do endoscopy. So this was Kussmaul back, late 1800s. The rigid esophagoscope was around again about at the same time. This patient's nice and comfortable, not saying a word. Schindler, who was a famous gastroenterologist, that's his wife here, the scope is a little bit smaller than it was in the 1800s. You get a good look at the esophagus, but that's about all you can look at. And the patient doesn't look like he's having that much fun. And here at University of Alabama at Birmingham, I'm proud to say that Basil Hershowitz, who was the first division director of gastroenterology at UAB, actually invented the flexible endoscope. Here, this is now a coffee room that we have on the 4th floor at UAB. he was performing this flexible endoscopy on this patient. He looks pretty comfortable, but here's Basil Hershowitz actually looking at the esophagus, stomach, and intestine with this flexible endoscope. This was about in the late 1950s, and this endoscope is actually in the Smithsonian Institute. So once you got a flexible endoscope, that changed the whole equation. So I talked about ERCP and tissue diagnosis. So here's an ERCP. Our scope is in the intestine, and we're taking an x-ray of the bile duct and the pancreatic duct. Refresh your memory on that cartoon I showed you about the anatomy. Here we can see that there's a narrowing or stricture of the bile duct. In this case, the pancreatic duct looks relatively normal. This patient has a cholangiocarcinoma, which we'll talk about briefly at the end, which can mimic pancreatic cancer. So here we're brushing with the little scraper, brushing the bile duct to get cells. We can see that the sensitivity of finding cancer, that is, how many patients with cancer will have a positive test? Only 3 out of 10, so you're missing 70% of the patients, so not a very good test. You can increase that a little if you actually put biopsy forceps in the bile duct to get biopsies, but you're still, as you can see, missing a significant number of patients. Can we do better? This is what we'd like to see at biopsy, where we actually have cancer cells in all this fibrous tissue. And as we've heard throughout the morning and this afternoon, pancreatic cancer tends to make a lot of fibrous tissue. So at the time of ERCP or on biopsy, you might just get this fibrous tissue rather than the cancer cells. So that's one of the problems that we face. Several other studies have shown that you can actually increase the number of patients that you find with cancer by the biopsy up to 65%, so maybe miss less than half the patients, but still, that's not good enough. Another point to just highlight is that if you find cancer on these brushings or biopsies, by definition, you have cancer. So if you get it, it's great. If you don't, you're still going to have to do another test. And along comes endoscopic ultrasonography. This is a cartoon of this, again, flexible endoscope here in the second part of the duodenum and a mass lesion here in the head of the pancreas that you can actually put a needle in and get tissue. This is a endoscopic ultrasound. I don't know if we need to cut down the lights just a touch. You can see this again, you turn the sound picture on. So it's like an abdominal ultrasound, but you're actually sitting right on the pancreas through the stomach. Here we can see a mass here, which invades the portal vein, and you can see the bile duct is markedly dilated and stops right there. So a very beautiful image of a pancreatic tumor. Again, on the left, you see the pancreatic tumor here. You see some of the vessels that are involved. And here you see a needle going through the stomach into the tumor to get a sample. Not only can you get a sample of the tumor, but also stage the patient at the same time. We saw in those last cases, you saw vascular involvement, but here we see a mass here abutting the vein. There's a small little node here, but in the celiac axis, lo and behold, there's another lymph node that you can biopsy, find cancer. That patient already has metastatic disease. You might want to use chemotherapy first rather than go to surgery. So the endoscopic ultrasound can help you stage a patient very well. Just to show you what kind of cellular material you can get with the ERCP brushing versus the endoscopic ultrasound brushing. Again, you've seen this picture before, and very piddly amount of cellular material. Here's the tumor here, abutting the vein. You put your needle in the tumor, and here you get much better cellular material. So very, very nice example of the disparity between what you could do at ERCP and what you can do at endoscopic ultrasonography. So how do you do in the U.S.? Well, it's really like a regular scope test. You go in, you can get it done and go home the same day. You have 2 screens. One screen is the endoscopic ultrasound or the sound picture, and on the other screen you have the endoscopy. Patient sitting on their left side. After you get your sample, we have our pathologist or cytopathologist actually in the room. You can give them the specimen, they put it on the slide, and can look at it right there. So generally, we can tell a patient after the test, before they go home, do they have pancreatic cancer, yes or no, and do we think the tumor is resectable, yes or no. So really a very powerful tool. Just as an example, 185 patients with pancreatic masses that had biopsy by a CT scan, more of an old-fashioned way, if you will. Of the patients who had a negative biopsy, 9 out of the 10, 90% or 9 out of 10 patients had a diagnosis made. Those patients who had the sample taken by a brushing or biopsy at the time of ERCP, 36 of those were negative. Essentially, all of those had a diagnosis made by the endoscopic ultrasound. So a very, very effective test. Just to show the amount of literature on this, there's been numerous studies. Overall, the sensitivity is about 85%. At our center, it's more like 96%. We'll show some of the difficult patients later, but it's a very powerful but safe technology. So let me just show you a video of how you do it. Taken from one of my colleagues. Here's the scope going down. Now we're in the stomach. The sound picture is turned on. We'll be seeing it move here in a minute. The celiac axis, some of the blood vessels here. We're moving the scope around. It's just like a regular sound picture test, like an ultrasound of any other organ. Lo and behold, here's the mass here that you'll see right here. It's a little bit light, but you can see the vascular involvement, even volume of the celiac axis. We can see by Doppler that's a blood vessel, so you don't want to really hit that. So we hear the needles going out through the stomach wall and sampling with a back and forth motion into the tumor. And that's what you'd come up with. Large cells, it's cancer. Very, very effective and actually remarkably safe. Is every mass we see at endoscopic ultrasound a cancer? Well, the answer is no. Here's a patient who has somewhat of a mass lesion in the head of the pancreas, a little bit peculiar. On endoscopic ultrasound, it was large and somewhat oblong, a little bit peculiar, but the biopsy here just showed normal glandular material. This patient had a peculiar variety of chronic pancreatitis. This patient looks all the world like somebody had pancreatic cancer, large mass lesion here in the head of the pancreas, abutting the portal vein. Endoscopic ultrasound performed, aspiration performed. This patient had lymphoma, which would require a totally different type of therapy. So even though the patient that I presented today almost assuredly has pancreatic cancer, there's that occasional patient that it's not pancreatic adenocarcinoma, and the cytology of those lesions can give you the answer, is it cancer, is it not? We have a lot of trouble sometimes getting the diagnosis of pancreatic cancer in patients who have chronic pancreatitis. Here's a pancreatogram or an injection of a pancreatic duct in a patient who has chronic pancreatitis. And here we see a stricture of the main pancreatic duct. We see a pancreatic stent is actually in place. The biopsy is performed. This patient has cancer. A similar type patient, chronic pancreatitis, an amorphous mass lesion is shown here. The biopsy here shows more of inflammatory cells. This patient had chronic pancreatitis and more of an inflammatory mass lesion rather than cancer. So very good in distinguishing cancer from non-cancer in the setting of chronic pancreatitis, which sometimes we have a lot of difficulty in distinguishing. But this test is not perfect. The proximal part of the bile duct, the hilum of the liver, and of course the intrahepatic ducts, you really can't see very well with endoscopic ultrasound. Which gets us really to cholangiocarcinoma, which are those cancers of the bile duct, either the lower bile duct of one of the earlier cases I showed you, or higher up where our biopsies and brushings are really not very good. EUS is very good to get a biopsy if the stricture is the lower part of the bile duct, but as I mentioned on the last slide, when the stricture is higher up into the hilum or even in the liver, you really can't get that high up to see them. Here's a patient who has a cholangiocarcinoma of the very distal bile duct. Here's a very dilated bile duct. There's a little bit of sludge in here, and close up here, there's a very, very small tumor right at the very end of the bile duct, very subtle, but biopsy positive. How good is EUS FNA in finding these cholangiocarcinomas really would depend on do you have proximal or distal strictures. As shown here, the sensitivity is a little bit less than what you'd see with the distal stricture, but not bad. But those really strictures high up where the patients present with jaundice or right up into the liver, we really have a very difficult time making a diagnosis. Can we try to make a diagnosis to really get the patient to surgery if the patient is a surgical candidate, or some type of neoadjuvant treatment, as we mentioned with pancreatic cancer? And the spyglass is basically a very small catheter that you place through the endoscope channel. You can actually place it up into the bile duct and try to visualize the anatomy. Here's a cholangiocarcinoma that you can actually see, and you can direct your biopsy, which is something we haven't been able to do in the past. How good is this technology? It's a little bit difficult to use, but if you compare just the tissue acquisition at regular ERCP, which I already told you is not that great, combined with the cholangioscopy, we're actually looking at the lesion and getting a biopsy, you can see it's significantly improved. So this is a better technique that we now have available to us. And lastly, there's also newer techniques. The one I'll briefly mention is confocal microscopy, where you're actually playing like you're a pathologist, where you can actually look at the tissue and see, does it look normal or abnormal? This still gets back to the problem that the oncologists want to know, do you have cancer or not cancer, and want to have tissue that they can look at under the microscope. But this is actually an evolving technology which might be quite helpful. So you have a small little catheter, and I won't go into the mechanics of how it works. You give a fluorescein dye, which the cells take up. Here's an example of a normal appearing colon, and with this confocal microscopy, this is how it looks when you turn the machine on and put the probe right next to the colon. So you're basically almost taking a biopsy of the colon that you can look at. You can tell the difference between normal and abnormal pancreatic ducts and bile ducts. Again, this is the small little catheter, the fiber that you put through the endoscope channel to the area of the stricture. This is normal appearing pancreas. Here's a patient who has a cholangiocarcinoma as shown here, where again the cells are look much different than in a normal patient. Again, this has been helpful in several patients where we weren't sure whether it's a benign problem or a malignant problem. Nevertheless, you still have the difficult issue of the pathologist and the oncologist would like to see the tissue on the slide to say, is it cancer or is it not? So what about ERCP? Well, now since we have endoscopic ultrasound, the patients that I'm typically seeing now, we do occasionally get brushings or biopsies, but we work very closely with our endoscopic ultrasound colleagues. So they would do, if we had a patient who had a malignancy or suspected malignancy, they'd get the endoscopic ultrasound first. Do they have cancer, yes or no? Is it resectable, yes or no? Then we move them over to the ERCP room where we could then know what type of stent we're going to put on. Are we going to put in a plastic stent or metal stent? So we work very closely to try to figure out what's best for the patient. So in contrast to the EUS picture, which I showed you, the patient is lying flat on their stomach. There's two nurses at the head. Again, we have the x-ray view and the endoscopy view. I mentioned the different kind of stents and the variety of different kind of stents that are available. If you decide to put in a metal stent, which everybody seems to want a metal stent, but the metal stents are very costly. They do last longer. It doesn't preclude getting a fine needle aspiration at EUS, so that's been a little bit of a concern in the past. Well, the patients, we don't know if they're going to get surgery or not. We know they have cancer, but let's go ahead and put in a metal stent. That doesn't preclude you getting cancer surgery, nor does it preclude getting a biopsy at EUS. If the patient's inoperable, these stents do last longer than the plastic stents. I mentioned about not precluding surgery. You generally don't want to put in these uncovered stents unless you know the patient has surgery, because you can't really remove them endoscopically. We do have covered stents, completely covered stents, however, that we can remove. And we're using those more and more with benign bile duct strictures. So here's just an example of a patient with a long stricture from pancreatic cancer. And you place one of these metal stents, which looks like kind of a screen door. It's a mesh, and the median patency of these are about a year or so. So tissue acquisition in 2012 for biliary strictures. This is just a cartoon of the type of strictures you see up in the liver, which are very difficult to get by EUS. So the FNA is really more for the distal bile duct and head of the pancreas. Higher up, we're going to try brushings and biopsy and or direct visualization with this cholangioscope. And these are complementary and not really competing techniques. So in conclusion, I hope I've convinced you that the technologies we have for clinicians are much better than they used to be for staging and diagnosing pancreatic and biliary malignancies. This has come about principally by the widespread adoption of endoscopic ultrasonography. Very good at diagnosing, staging, and remarkably safe. We work as a team combining ERCP and EUS when the patient comes to Birmingham from the hinterland in South or North Alabama. We're able to get everything done in one setting. We can tell the patient they have cancer or not, put in the appropriate stent or not, and then direct them to oncology, surgery, or whatever. So we really work as a team. As many of you knew, our team in Alabama. So I'll stop here and, thank you for your attention.